Welcome to the Groves Connection. I'm your host, Dr. Robert Groves. Healthcare has been credited with pulling us out of the last recession. Between 2006 and 2016, healthcare jobs grew 7 times faster than any other industry, providing much needed work to those in need at the time. Healthcare is also the economic engine for many communities, particularly those that are rural. And so we have to take that into account when we talk about the speed and the how of healthcare transformation. But the costs are staggering, and you've heard many, many times they're unsustainable. Well, so far we have sustained them, but at what cost? 100 million Americans struggle with medical debt today. It remains the #1 cause of personal bankruptcy. And 1 out of 2 of us in the last year put off needed care because of healthcare costs. It's cold comfort that we've come so far when so many don't have access to the system. And yet there is reason for optimism, but it's going to take all of us doing what we can to help turn this system around. And in order to do that, we need to understand the system, why it is designed the way it is today, how we got here, and what we can do about it. And so that's what the Groves Connection is about. I'm really interested in having in-depth conversations with insiders and experts so that I can learn what they know. And I'd like you to do that with me. These conversations start usually with inquiring about how they got where they are. What was their life journey like? What motivates them? And I think it's interesting to find out what kind of people they are before we hear what their positions are and what we should do. But we will get into the details. We'll talk about innovative care models, but we'll also talk about what they believe are the solutions, the things that can get us to the next level so that we can have a much more accessible, affordable, and equitable system. I think that's what we all want. And we know that we have the resources to do that. It's a matter of understanding and then influencing the trajectory of healthcare policy and managing our own healthcare as best we can. I invite you now to get curious, and I'll ask you, are you ready to connect? Action. Dr. Brent James, welcome back to the Groves Connection.
It's a delight to be back with you, Robert.
Yeah, it's been a while, and unfortunately we are not able to be in person this time. That was a highlight for me, being able to actually sit down across the table from you and have a discussion. But this is a close second for sure. So I'm looking forward to it.
Me too. I think that we'll have a delightful discussion. If it's anything like the last, I expect to learn a lot.
Where I want to start, I think the pandemic is, if it's, still classifiable as a pandemic, that might be an interesting discussion in and of itself. But it's in a new and interesting phase now that we've got a much higher level of immunity across our population. And apparently the strain that we're dealing with now is not as deadly as some of the original strains, or some combination of those two, immunity plus virulence. But how do you see the current phase and how we're responding to it? What are we getting right? What are we getting wrong? And then we're going to go back and talk a little bit more about, in hindsight, what lessons are there?
Well, first, probably this isn't the first time that we've had a similar pandemic. I read a fascinating article about something called the Russian flu. Now, back in those old days, any respiratory virus was considered influenza flu. This particular one in the late 1800s, it ran for about 15 years, a series of bursts through about 15 years. Some people hypothesize, as they did in this article, that it was a coronavirus, primarily because it affected mostly the elderly. To influenza, of course, hits the young, especially the very young, fairly hard, as well as the elderly. Coronaviruses seem to spare the young. Children and young adults. It ran in various surges, various waves across about 10 or 15 years. And one of the things that we routinely see, as the article pointed out, is as a virus evolves, that it becomes less virulent, so less likely to kill, and more contagious. In fact, there's the belief that many of the coronaviruses that we routinely see today on a broad scale, what is it, about a third, a quarter, a third of all, little viral head colds are thought to be coronavirus, something like that, if I recall correctly. that we're seeing the 100 years later tail
Gotcha.
of that particular thing. So if history repeats in that sense, it appears to be so far repeating in just that sense. That's what you'd expect.
Okay.
So you'd expect to see little waves continue to hit for another decade, noticeably. But with each one more contagious, spreads more easily, and less virulent. So lower hospitalization rates, lower associated mortality rates is what we would expect to see. And at least for the variants that we've seen so far, they have so far appeared to be following that pattern. Now, I'm trained in epidemiology, but I'm not a virologist. So I'm a little outside of my area of expertise, but it's great fun to read about it. All of us can read about it. Then what a friend of mine says, everybody's an expert. So,
well, these days that's true, isn't it? Everybody seems to be an expert. Hey, I have a quick question about the coronavirus natural history that you just outlined. I mean, one of the fears that's still out there, at least in the press, is, well, you never know when we're going to get a much more virulent mutation, and that this could turn ugly. In the influenza epidemic in the early 1900s, there seemed to be a resurgence of a more deadly virus in part 2 of that, if I recall correctly. And what do you think the chances of that are? Now, from a propagating your genes perspective, it makes sense as a virus, right? If you're evolutionarily,
you don't want to kill the host. It's a bad idea to kill the host.
Yeah,
it's gonna limit your rate of spread for sure if that happens. So from an evolutionary standpoint, it behaves exactly as you would predict from that standpoint, and as they've behaved in the past. Is there a chance that could happen? Yes. Is it a significant chance? Now, this is a judgment call.
Yeah.
My answer is probably not. Quite a low risk. I actually think you look at some of the other viruses that are circulating out there, there's some truly nasty stuff out there. Ebola being the poster child, but believe it or not, compared to some of the others, relatively mild for something that nasty. There's a bunch of them. I think the chances that one of those would go wild is higher.
Fair enough. Yeah. Okay. And that takes us to another topic that I want to pick your brain on. That is our ability to assess risk, and which is non-existent, it seems like, but and how that influenced our response to the pandemic. And I think that some of the policies that we implemented made sense early on, but the persistence of those policies maybe wound up hurting more people than the pandemic. Now, that's a hard thing to say because I know a lot of people have suffered in the pandemic. People have lost loved ones, et cetera. But there's also a very real other side to the story when we shut down the economy. So
this became fairly evident fairly early, just in passing. We know that anytime there's a major economic downturn, especially of the sort that we've just experienced, that we may be re-experiencing, frankly, if we now put the country into recession, there are completely predictable health consequences measured in mortality. It kills people each time. It's so I was watching for it. I was tracking for it. This is not a new idea. This is not a new phenomenon. Early on, I encountered an article in JAMA. It was fascinating at one level. They were looking at excess mortality, which is a really good way to track these things. Given baseline mortality rates, how much excess mortality do we have? And then they were classifying the excess mortality. What they found in their data, it's observational, so it's not like you're doing a trial, but about 2/3 of the excess deaths tracked back to the virus, SARS-CoV-2. About 1/3 tracked back to the economic consequences of a downturn. Deaths of despair.
Yes.
Alcoholism rates going up, violence rates going up, drug abuse and other forms going up, just a whole series of things that make up the whole pattern. The thing that was funny about it is they were questioning their own data because they said, how could this be? Well, the simple fact is anytime there's an economic downturn, we see this, and it's a well-known phenomenon, and it's exactly what you would expect. There's a secondary factor with it too, though, Robert, that's troubling. It turns out that for people under 65, the risk from the secondary effects of an economic downturn, those deaths of despair, et cetera, were much higher than the risk from coronavirus. So for somebody under 65, the chances that you would die from those secondary consequences was, one study estimated 3 to 6 times higher. Wow. So effectively what we were doing, we were trading off deaths in the 20 to 65 year age range. Let's just pick a 45-year-old in order to save people who are older than 75 or 85. So the funny story, recognizing that some of this was going on, I asked a number of my friends in the field, but I said, contrast for me the death of an 85-year-old versus the death of a 45-year-old. If you're forced to trade off, would you prefer one versus the other? And at the time, many of them said a death is a death. They wouldn't differentiate. Now with my training, I look at years of life lost, right?
Yeah.
And the death of a 45-year-old who has, 45, maybe even 50 years of life expectancy, perhaps, for well-managed life in front of them versus an 85-year-old who has maybe 5, it's a pretty easy trade-off. Another way of saying it, I'm pushing up on 72. I look at the death of one of my children, one of my grandchildren, and would it be a better trade-off to lose me or to lose one of them? You see what I mean? Yeah. And for me, that's a pretty easy trade-off.
Yeah.
Now, I think that when you're being rational about it, I mean, you're just doing it on the science, on the numbers. Everybody agrees with that. The trouble is that fear distorts the picture pretty badly.
Yeah. So is there anything we can do about that, or is that just human nature? Is this going to happen again and again? It seems like there's almost nothing that will help us prepare for or balance risk. I mean, do we need to educate more about risk assessment? I mean, what can help with this?
So a related field, one of the things you encounter in quality improvement theory has to do with why there's so much clinical variation. And the argument is that the nature of medical science is changing. So there's this fun literature, and it has to do with the nature of the expert mind. We're experts around a particular topic as physicians, you see. When it comes to pattern matching, we're wonderful, almost magical. We don't know how to replicate what goes on analytically. Basically, what appears to happen, if you review that literature, is that we take a complex problem, we break it into sub-buckets. We pattern match within sub-buckets. We pull forward alternative hypotheses, a list of choices. Then across the buckets, we look for commonalities. Gotcha. By the way, this is how IBM Watson actually works. It's a pattern matching algorithm that tries to mimic the way the expert minds work. Much of this study happened in medicine, but a great deal of it happened with experts outside of medicine, but we know how it works. So contrast that approach of pattern matching, where we do wonderfully well, to rate estimation. That means you have to summarize a rate across a group over time in your head.
Gotcha.
That same literature shows that when we ask an expert to do that, we're at least as bad on that side as we are good on the other side. You can't do it. It's called anchoring. You're dominated by 2 or 3 recent cases that you happen to recall.
Yeah.
Or if you had a particularly dramatic case in your deep past, good or bad, that becomes your lifetime experience. That is why when someone says, in my experience, you should not trust it. Well, when you're talking about risks, they're all rates. It's not pattern matching, it's rates.
Yeah.
And one of the really bad things that happens is that, we focus on one risk and we lose track of all the others. We get so monomaniacally focused on that one risk that we lose track of all the other factors that are in play, you see.
Yeah.
So as a statistician, way back when I was at the Farber still, we used to build what we call proportional hazards models. A proportional hazards model, you try to identify all the risks and say, okay, what's their relative scale? The way I used to tease my students about this, even during coronavirus, I'd say, okay, so 2 questions. First question, if coronavirus doesn't kill you, you're going to live forever. And they'll say, well, no, you don't live forever. The mortality rate's still uniformly 100% given enough time. Something will get you. And if it's not coronavirus, it's going to be something else, isn't it? So fairly early on, I didn't build formal models, but I had some sense of the other routine risks in my life. And I started to throw coronavirus into that mix. Yeah.
So let me ask you, so what you're doing is you're saying, okay, I'm following the data on coronavirus. I know what my personal risk factors are or are not, age, coexisting conditions, whatever else. And I have some idea of what the risk is today for being hospitalized or dying. Let's say it's 1 in 1,000, just for the purposes of discussion. Then you're throwing that in with the bucket of all those other things that you do every day that have that same, log level of risk. Is that?
That is correct.
Okay.
Now, coronavirus, as I mentioned, I'm pushing up on 72. I have 2 risk factors. So compared to others in our society, it's relatively high for me. Now, at the moment, though, I'm vaccinated. I believe in vaccines rather deeply. That's another fun discussion. Is do people across the profession believe in vaccination? And if so, let's discuss revaccination and why you're doing it. My risk from dying from operating a motor vehicle is in the same general range as my risk as a 72-year-old with 2 risk factors of dying from coronavirus. Do I drive my car? Sure.
Yes, of course you do. Of course you do.
Yeah. Now, I'm one of the strange people out there. I really am a geek. And when I get in my car to drive somewhere, especially if it's long haul, I often think about the risk I'm undertaking. And it's a bit of a reminder to be, as an old guy, I better be on my top game and I better pay attention to what I'm doing.
I remember you saying this in our last interview. You mentioned that the risk was in the ballpark of risks that you take every day. So do we just become numb to those other risks, or is it because they're so necessary, or do we not think in risk terms? What?
Risks that we routinely face move to the back of our mind. Didn't kill me last time. Why even pay attention to it? But they're there. They're definitely there. They're always there, and they could happen, you see. But when you're building proportional hazards, you pull them all in, and then you see a more complete picture across spectrum, and you realize you're making trade-offs. It's always trade-offs. Now, in fairness, as I watch the country around coronavirus, you are making decisions in the face of incomplete data, which is always hard. It's always a judgment call. I do believe that some people did a much better job of it than others. That they weren't so, again, tightly focused just on this one risk that they lost track of the other risks. I mean, we're now starting to understand what it's done to younger populations. It's starting to appear in the literature. We're understanding what it did to our children. We're understanding that there was a price from elderly people without coronavirus dying from isolation and loneliness. We're understanding the consequences of people being too frightened to go into the ED when they had that stroke or that heart attack. To be honest, though, when you look at the literature around it, I don't expect humans will ever be able to make those judgments seat of the pants. I just don't think we can. I think the wise among us will realize that it's a balanced risk. Get out your computer, run the numbers. As an old statistician, I've done an awful lot of modeling in my life. And as a result, I have a very high degree of skepticism about modeling. They're useful. They're useful. I don't want to take away from that. It's not that they're not useful. They are. But they always have fairly serious limitations. And so I don't trust them completely. I realize that they're an estimate and that you better take that into account when you think about it. Well, what will happen is the fear will blow away, the fear will stop, and then we'll look back with 20/20 hindsight. And I think we'll have a much clearer picture of what happened. Of course, the real trouble is by the time the next major pandemic happens, we'll have forgotten all of this.
I guess one of the things that I saw, and you tell me if you think I'm correct in this, is that in our zeal, meaning our public institutions, to deliver one message, we stepped way over the line and ignored nuance. There was a point in New York City where there was a bill that wanted to mandate masking in kids while in school while nobody else had to work. That is upside down and makes absolutely no sense. But even down to the level of what our, CDC and so forth, there's so much emphasis on, no, we have to have one message and say it over and over again, that even when the data changed or there were subtleties, they were ignored. And, people are pretty smart. They pick up on those things.
I don't believe that our leaders believe that people are pretty smart, Robert. I believe they were trying to drive public behavior, and I think they violated a core principle. They should have been honest.
There you go.
And part of being honest is to include the level of doubt associated with it. To say what you really know, where there's open questions. I realize that's hard, but that's such a core principle. Of course, what happens is when you're not honest, not completely honest, then the truth comes out. It destroys trust. And as trust declines, your ability then to lead a public effort disappears. And we've seen that happen. In fact, it's a scourge right now on some members of our society where they massively doubt vaccination. Yeah. And my answer would be, we earned that fair and square. We built it. By the way we behaved. I don't know if we should blame it on them or blame it on us.
Where are we with vaccination now? I think you and I would both agree that everybody ought to have the initial series but how many boosters does it really make sense for people to get? How far down in age should you go with vaccination? And those sorts of questions are paramount right now. Parents are confused.
Now, you're getting well outside my area of true expertise. This is virology and immunology. But all of us studied that to some degree in our training. Yeah. As you recognize, it's the difference between humoral versus cellular immunity.
Right.
So you have B lymphocytes. They replicate very, very rapidly. They have a relatively short half-life. So anytime you're exposed to an antigen, and we even now pretty well understand the exact mechanisms by which some sort of a T cell typically will pick up an antigen, bring it to a B cell, they start to replicate, and you get this surge, this curve of surging, circulating antibody. Mm-hmm. Circulating antibody is useful in two ways. The first is, of course, one end attaches to the antigen, to the viron, the viral particle. The back end of it then is an attractor for killer cells in various forms. So that's a key part of the immune response. Second thing, we call them blocking antibodies. If we have a bunch of antibodies stuck to the outside of that viral particle, that viron, it can infect a human cell. So blocking antibodies. So it's good two ways. What happens though is because the lymphocytes have a relatively short half-life, after that stimulus goes away, they die out. And so they fairly rapidly die out. And so you get this curve. I actually have some beautiful articles that show the response curves. And what you'd expect, beautiful response curves, peaks up, and then it over about 6 to 8 months trails down to close to undetectable. Of course, at that point, what we're relying on is cellular memory, CDT plus cells and T cells, if I read correctly, and trying to refresh this in my head.
Yes.
They have a very long half-life. They last decades, sometimes an entire life, depending. If I'm re-exposed, it means that my immune response happens much more rapidly, usually measured in hours, a day at most, but It happens very rapidly. So the answer, I have a close friend. We went to medical school together. He's a fully board certified urologic oncologist, trained at Sloan Kettering, pretty hot stuff. Another old guy though. He's currently working at the Veterans Administration Hospital here in Salt Lake City. And he says, hey, Brent, he says, they're trying to get me to get a booster. What do you think? And I said, well, Bob, I said, if you get a booster, you're going to re-expose yourself to the antigen. Beta lymphocytes are going to go crazy. You're going to get a nice circulating antibody spike. And over the next 6 to 8 months, it's going to peter out and go away. And there you go again. Otherwise, if you actually get exposed, it will take a few hours to a day or so for you to get a full immune response going. Is it going to hurt you or kill you? Nah, you're probably well protected. I mean, think of all the other things we vaccinate for and rely on long-term cellular immunity. I mean, we have a long, long list. Yes. I got vaccinated for pneumonia. Do I get vaccinated every 6 months?
I hope not.
Good heavens, no. How about Shingrix? No.
Yeah.
How about tetanus? A good old Tdap, right?
Yeah.
Tetanus, diphtheria, and acellular pertussis. Do I get those No. And what I'm relying on is cellular immunity for all of them across the board. The downside, if I get really snarky, I'd say, oh, what you're telling me is that mRNA vaccines, this new vaccine technology, mRNAs, don't produce cellular immunity. That's why we have to get revaccinated. They could make a secondary argument that, no, you need to be revaccinated because the virus is mutating. Oh, wait a minute, guys. If the virus is mutating, I need a vaccine for the new virus, not the same old vaccine for the old virus, don't I?
Yep.
Well, but you're saying use the same vaccine. So when Bob asked me, what should he do? I said, tell you what, I know that you plan to take a trip. He's an organist. He's a great organist, and he likes to bike. And I said, you'll be at fairly high risk. You'll be traveling. You'll be in different countries. You'll be at fairly high risk. About 2 weeks, 2 weeks before you leave on that trip, get vaccinated. That way you'll get that nice circulating antibody spike. When you're going out. Now, he could have argued that hanging around the VA hospital is an even higher risk than traveling Europe. You can make the choice about that. But if you see the idea there, but you see the reasoning behind it?
Oh, yeah. So what you're doing is you're timing the vaccine to an event in his life that is going to increase his risk of being infected. And so even though he's protected from hospitalization and death, if he doesn't want to have a cold on his trip, this will help prevent that from happening. Is that
even worse still, get a positive COVID test and not be able to return to the United States. Now there's
there you
real
go.
hassle.
That's the biggest risk. Yeah.
So there's another element in this too, Bob, that I find strange, unusual. Arguably, by far the best vaccination you can get for SARS-CoV-2 is to actually contract the disease.
You would think, right? I mean,
I've seen the data. People who have been vaccinated have slightly higher risk than those who have had a documented positive test. They've survived it. So we could argue about, well, how intense was it? That particular study published by CDC, I've got it right here. It shows, of course, if you're unvaccinated, your risk's way up here. If you're vaccinated, it's way down here, 20, 30-fold decrease in risk. But it turns out that for that low vaccinated people risk, if you had a positive test, a confirmed positive test, your risk is about half of those that have been vaccinated. Of course, the people who do best if they get vaccinated and have the disease. So there you go.
Yeah.
So I only know of 2 countries in the world. There may be more, but I only know of 2, Australia and the United States, that don't treat a positive test as vaccination.
Right.
And it's crazy. It's crazy. So I've told you earlier, I was not as frightened by SARS-CoV-2 as many others are, and I was perfectly willing to travel. Now, I'm not an idiot. I got vaccinated. I actually participated in a randomized controlled trial with a good protein-based vaccine, which I liked a little bit better than an mRNA vaccine. I got Novavax because I just thought it was probably a little bit better. I'm now on a follow-up trial, so I've been boosted on it, but they're tracking immune system response. I go in and donate blood every once in a while. I figure as long as you're going to say these sorts of things, you ought to be willing to contribute to the science, put your body where your mouth is, kind of. I have no problem at all wearing a mask.
Right.
Frankly, my personal style is such that I'm a natural social distancer, if you know what I mean.
Yes,
I'm not all that social.
Yeah.
So, it's funny. I know I've had at least 6 major exposures to SARS-CoV-2 of people very close to me, my wife, my children, other places where I went and everybody came home with it. I've never converted.
Wow.
And I participated in another trial where I got antibody levels up until I got vaccinated, of course, but now I've got circulating antibody, but it's from the vaccine. So,
and it's
here
possible.
I am traveling Europe. I'm traveling Europe, and I can go anywhere, and everybody's accepting a positive test as immunization, except the United States and Australia.
Is that because it's hard to do or expensive to do, or why is that?
You think you might have something, you go down and get the nasal swab and you get tested. That's all it is. So why is it this country, now this is a belief, and you
Okay.
could argue with me on this, I think it was a political response that we were so frightened. I mean, I saw standing shoulder to shoulder with Saddam Hussein. He gave us the phrase, the mother of all wars, right?
Yes, yes, yes.
Well, this was the mother of all pandemics,
Oh, my.
that we were suffering the worst pandemic in the history of humankind somehow. And the response, the political response to it is that I think that we checked our rationality at the door a little bit on this one in many circumstances.
What you pointed out earlier, the loss of trust. I mean, even reasonable people will intuit that if I've had the disease, isn't my immune system better prepared than a vaccine that just looks at one part of this thing? I mean,
exactly. You got it. The vaccines pick one protein sequence, usually in the spike of a coronavirus, right?
yeah.
If you actually get the disease, you're getting many antigen sites, a big number. So you're getting a much broader immunity. And especially if I'm getting variants, if I'm getting some mutation going on, I would expect to have much broader cross coverage.
Right. I recently saw that I think estimates are that maybe up to 90% of our population now has either been vaccinated or infected. It had at least one dose of the vaccine or been infected. At that level, is there any advantage to continuing to test and fret about the virus? Is there a reason? And I know this is bound to be controversial even as a question, but in my mind, I'm thinking, gosh, if I got sick, does it matter? I don't want to spread whatever it is I have, right? And I think that lesson has come home. As a physician, I used to go to work no matter what, right? Unless you were,
me too.
Yeah.
I can stay home and be miserable by myself, or I can go to work and make other people miserable too. Yeah. Okay.
but I've learned that lesson. I think that it's probably kinder to those around me. And now, of course, because I'm able to work remotely when I need to, et cetera, that it doesn't make any sense for me to go and expose people. So is there any advantage to testing now? And especially when a lot of it's happening at home, we're not even sure if people are reporting it or.
I really hope that the idea of masking will stick with us. During that time period, I've had at least 3 significant viruses that turned out not to be SARS-CoV-2. Just standard old viruses like we all get every year.
Right.
I think that the right idea is, now I really like KN95 masks. Maybe that's one of the reasons I didn't convert. I liked them from the start of the pandemic, and I tracked a few down, and I'm perfectly happy to wear them anywhere. You get a surgical background, and hey, this is just like going to work every day.
That's right.
Who cares? And you kind of fit them to yourself, so you get a relatively well-fitted KN95, so you got pretty good protection. I hope we will wear them when we ourselves have sniffles. Yeah. The reason is what you're really doing is preventing spread out from you.
Yeah.
A KN95 will protect spread coming into you to some degree. A standard surgical mask, not so much. A cloth mask may be worse than nothing, frankly. Yeah. Looking at that little literature, some of the articles in that, I plan to, in the future, anytime I believe I am carrying a virus, even if I'm not sure I'm in the fully infected period, I plan to mask up out of consideration for those around me. If we can get that attitude out there, that's a good attitude, and develop that kind of a culture. You see what I mean? Now, I don't believe that comes from mandates. I think when you post mandates, people dig in their heels and hit back.
Yeah.
But I think sharing the idea and centered around just consideration for others and starting to model it and talking that way, I could see where that could happen. I really hope that'll happen. On the other hand, forcing 2-year-olds to wear masks on airplanes and throwing people off the airplane if they can't keep the mask on their 2-year-old, come on.
Thank you for sharing your insights and your opinions. And I want to wrap up this section because there's so much more I want to get to here before we call it a day. So what do you think are the lessons we need to try to remember, even though we know we won't after a generation or so?
The first would be, especially if you're in a position of public trust, tell the truth. Be honest about what you know, about what you don't know. Share your vulnerabilities. Sure. Your lack of perfect knowledge. I think people feel like in those roles that they have to have perfect knowledge somehow. You don't. Assume that those people on the other side of the line are just as smart as you are. They are, by and large. I think at the same time, another idea, the whole premise underlying modern science is that you can challenge beliefs and suppositions and current data. One of the most disappointing things I saw is early in the pandemic, people were quite frightened. They were worried about how bad this could be. I get it. Everybody was. People were building some computer models that were showing potential catastrophes. I mentioned earlier, I don't trust modeling completely, and especially when you have poor data. What I saw happen early on is some members of our profession started to see early data in small natural experiments. What was that cruise liner, the Princess something or another? Mm-hmm. And they pointed out that the experience in those settings wasn't matching what we were getting from the modeling. And we as a profession did not seem to be able to accept that message. We did not seem to be able to have someone challenge our unsubstantiated beliefs. It's what it means to be a clinical scientist, you know.
Well, to characterize this a little bit further, I mean, I heard you, and this is clearly something that has really bothered you, and I understand why, but one of your colleagues who, you know, his transgression was merely to question that exact assertion, and you described his experience after that as being savagely attacked.
He was not treated kindly. You know, he made the fatal mistake of participating in social media. I think that's probably a bad mistake.
Yeah.
Now I'm really showing my age, aren't I?
You know, I have to tell you, I have not been able to sign into my Facebook because there's nobody you can talk to there for 2 years. I think I'm the better for it.
Yeah.
You know, thinking about this personally, I guess it's human nature when, you know, when I personally have a strongly held belief and it's challenged, my first initial reflex is to defend.
That's right.
And what I'm personally trying to do, and it's not easy, I will admit that, because somehow we get wrapped up in our beliefs, and it's as if you take those away, somehow, I don't exist, or, everything that I've hung my hat on is wrong. Well, what does that mean? And it seems that way, even though it may even be a limited part of what I believe. But what I'm trying to train myself to do, and I use it as a little mantra in my head, is get calm and get curious. Instead of pushing back immediately, it's just like, all right, take a couple of deep breaths, settle down, try to hear what that person is saying, and then investigate.
Right.
And it's so hard to do. It's common sense, but it's so hard to do.
A classic text, it's called Crucial Conversations.
Yes.
A friend of mine introduced it to me, one of the finest leaders I've ever met. But it comes down to his honesty and respect.
I could not agree more. And, for those of us who find ourselves struggling with that, it's still worth it. You got to keep trying to get better,
Yeah, I think we all face this every day. I know I do, at least. And I have to remind myself and repent a little bit and say, I did it again.
What I'm learning too about myself is when I am absolutely certain I am right, I am at most risk of being wrong. I'm learning a lot more about the red flags in my own mind that tell me something's up.
I went through a surgical residency a long, long time ago. And at the time, about 1/3 of general surgery was stomach ulcers. Mm-hmm. We did it all the time. We had all these long conversations about vagal nerve. Then these two crazy people in Australia show up and say, hey, it's not stress related, it's infectious. And I remember when I first heard that, because it flew so in the face of everything we all knew. I mean, did we ever know that? Committed to it. It was 1/3 of our practice. Think of all the people that we were cutting open and cutting chunks out of their body. I'm not proud of some of the things we did. It was the best current knowledge. But I think that we visited some great harms upon people in the pursuit of good. I will admit, our hearts were pure, mostly. But on the other hand, what would it mean if we hadn't been able to see those new truths? And see, that's what happened early in the pandemic. we were so caught up
Yeah.
that we couldn't see the new truth. And I think that didn't help us.
I think those are great messages. Be honest, treat people regardless of their views with respect. And if you find yourself getting defensive, get calm and get curious because something's up.
I like that.
I want to switch gears now a little bit because I want to go into your wheelhouse for the second part of this discussion, and it goes by a lot of names. You know, value-based care is the popular one today. A recent JAMA publication indicated that about half of doctors now work for hospital systems, and those systems, 90% of the compensation is RVU or fee for service. So even if they have value-based contracts with insurers as a company, that's not trickling down to the docs. They're still paid for production. And so, you know, and one of the reasons that's important to me is because I'd started to get a little discouraged by the fact that, well, we've been working on value-based care for how long now, and it doesn't seem to be doing anything to control the cost curve, although you can argue you should have seen what the cost curve would have been like without this. That's always a tough one to counter. But I'm wondering about your view on the state of value-based care today, where we are, and whether you're optimistic, pessimistic, somewhere in between.
So the first thing I have to say, Robert, there's no question that it's growing. I have a series of forward-looking indicators that I routinely track just to kind of keep track. There are 4 or 5 of them. And there's no question that it continues to progress. So it's not that the world is moving to a better place in a rational way. I mean, the evidence supporting it's overwhelming. It really is. The frustration is that it's not moving fast enough.
Yeah.
Frustrating because you sure wish it would have taken hold a lot faster. It's a common topic. My main academic appointments at Stanford University, Stanford School of Medicine. I'm in the Department of Medicine, but with Arnie Milstein's Clinical Excellence Research Center. This is a real common topic, but it's moving at its own dumb rate, just like life seems to do. You know, I think that what's really driving it underneath, so this is an idea, hypothesis. This is in my experience, so don't trust it. I think it's the fact that one person's waste is another person's income.
Yeah, well, that would be a reasonable hypothesis. Yeah, well, it's the biggest, when you get to 18, 20% of GDP, you can't ignore the economic engine that healthcare is for a massive chunk of society.
I've got to get it published still, but I've got a great model, a general model for quality associated waste. Deming's idea that as quality goes up, it causes costs to drop. Causal mechanisms, basically a mathematical proof. It's kind of pretty. This is where in 2010, probably the best report, Institute of Medicine expert group. It was actually at the press conference for the release of our report that we said a minimum of 30%, probably over 50% of all spending in healthcare is quality associated waste, extractable waste from a patient's perspective. So I built it into a general model, and I really like the model. Of course, I built it, wouldn't you know? It's number one, as far as I can tell, it's truly comprehensive. I've never seen an example of waste that doesn't fit within it. That's pretty. It turns out waste is nested, and to get accurate estimates of total waste, you have to take into account that it's mathematically nested. So you got to take out care that shouldn't happen at all before you estimate the efficiency of care.
Okay. All right.
See what I mean? Yeah, it ties directly to payment mechanisms. So it turns out it always takes an investment to take waste out.
Yes.
And so far, every instance that I've seen, it's always the care delivery group who has to make the investment. Well, the question is who makes the investment and who gets the waste savings?
Yeah.
And they don't necessarily line up, and it depends on how you're paid. So under fee for service, most of the waste savings go back to the insurers.
Yep.
Under per case payment, the only place where it fully aligns to those who invest getting enough to cover their investment, hopefully with a little left over for the next project, is if you're at some sort of shared risk. So what we see are payment mechanisms, deeply ensconced systems built around those payment mechanisms that are hard to change. And that also locks it in to some degree. When I model it, about 45% of all waste elimination opportunities on my models, now we can debate those, about 45% comes at the level of population health. Oh, another reason I like my models. It turns out that population health is a subset, this thing we call population health. Social determinants of health is also a subset.
Got okay. Now I'm
Interestingly,
following.
they're built in, about 45% population health level. What it means is you really go after reducing hospitalization rates. That's where it's easiest to see. So here's an example. We published it in 2016 in JAMA. We deployed better primary care, a series of chronic diseases, type 2 diabetes mellitus, heart failure, depression was a big one, treated as a chronic disease or a series of diseases. Ran a big trial, about 160,000 patients. We showed that by really making the primary care system work better, now it increased the cost in primary care. This was a trial of about 160,000 patients, mostly commercials, some Medicare in there, but mostly commercial. Cost about $3 million a year to deploy it. It was a 4% hike in primary care costs. Hospitalization rates fell by 22%.
Wow.
Visits to specialists and
That's
outpatient
incredible.
procedures fell by 21%. So while we spent about $3 million a year, we extracted about $16 million a year in medical expense. It was more than a 5-to-1 ROI, return on investment. All right.
Yeah.
And it came from better care. I mean, it's in the article. You can see the better outcomes. So better outcomes, lower costs, what's not to like? Who got that $16 million?
The payer.
The payers.
Yeah.
Yeah. And so you have this alignment problem, you see, back and forth. Dr. Mark Ott at Intermountain Medical Center, he came up with what I call a backdoor approach to thinking about surgical supplies. We ran something called activity-based costing, so we knew the true cost of everything he used in surgery. He had a kid who had to take a year off from medical school because of a health problem. He got better. He wanted some work. A young man attending medical school. I better be a little more appropriate here. Well, what he'd do is sit in surgery for a common case type, like a cholecystectomy or an appendectomy. And just as the surgeon used different things, it said, oh, here's what that costs. And he said, here's some other alternatives to that, and here's what they cost. What he was doing was making it transparent to the surgeon. They didn't know this stuff. They got way into it. What Mark showed was, I think his best year was about $43 million in reduced surgical supply costs.
Wow.
He
That's,
broadened it. That's across a smallish system here in the West, a smallish system, but there's serious money. Of that money, over 38 million went back to insurers.
Yeah.
So what you see is this misalignment.
Yeah.
Now, on the other hand, coming back the other way, I was talking to Chris Chen, who runs Chen Med. Have you bumped into Chris and Chen Med? So
I know about it. Yeah.
He uses a concierge model, no additional payment. It's pure Med Advantage. He insists on capitation. He's a primary care practice. He gets full cap, and then he buys hospital and specialty services as a practice for his patients. So he gets the full premium, right?
Right.
He tells me, he showed me data, he's got a 40 to 50% drop in hospitalization rates.
Wow.
He preferentially targets Med Advantage populations that are at the highest risk. They tend to be poor and underserved, just in passing, which is kind of cool. He does a concierge model, averages about 400 patients per physician-led practice. And I love how he says it. He says, Brent, he says a typical heart failure hospitalization, what it costs me is about $15,000 a pop. He says $15,000, if you avoid that heart failure hospitalization, that'll buy an awful lot of really good primary care.
Yes, indeed.
He's made that a viable model. And he can get capitation at that level. And he's been expanding hand over glove. The same thing, the thing that's a real marker, private equity money's coming into this. Groups like Oak Street and Morecare. And you understand those guys are just in it for the money. I mean, the investors are. I'm not talking about the physicians, but the investors. And what they see is a real financial opportunity here. It all comes out of the height of the hospitals.
First of all, I have nothing against capitalism. I am a capitalist. I don't think it works in healthcare for a variety of reasons, one of which is there's no transparency. You don't have a market, and so how could it possibly function?
I'm with you, then we're on the same page. It doesn't work very well in healthcare as a market.
But here's my question. So if we take this out to, let's say, a hoped for logical conclusion that ultimately we're all functioning under capitation to deliver healthcare. That means really that, just like every other function in our life, we'd have to have a budget, because right now the estimates are made by what would you have spent if you're in fee for service, and the delta is then what you can capture in a capitated arrangement. How do you set that price?
So I think if we come to the level of a full practice or a system, Robert, that a market could work. It doesn't work at the level of a clinician interacting with the patient. Ed Hughes at Northwestern, he's convincing to me, at least on this topic. 1776 Wealth of Nations, Adam Smith, the original text on markets, it lays out 4 factors for a market. Healthcare at the level of a clinician interacting with the patient, all 4 of them badly violates it. Across the board, there is no market. But the argument is when you come to the level of a system, you can get a market, and capitation is clearly at the level of a system, a more aligned approach.
Right.
Now, the trick is you've hit on the other thing. It's that lack of transparency. Frankly, we have a group of electronic medical record systems that are primarily designed to optimize fee-for-service payment. They're a terrible burden on the clinicians involved, and in my mind, to some degree, actively damage care. So as part of that transition, we may need to rethink frontline transparency. By the way, when I say transparency, I don't mean comparative data comparing one physician to another. I mean so that a clinical team can have the clinical decision support as they act to connect their actions to outcomes and get it right. Here's the trick. The forces behind it are so strong, and the theoretical framework backed up by empiric data are so compelling. It can't not happen.
Yeah, it's when, not if.
It's when, not if, and it's just the steps in between and the frustration associated with it.
Yeah.
And by the way, it's what I thought I was getting into when I entered medicine. I think it will allow us to be real doctors again, a life of service to those that need.
That is, oh my gosh, you have touched on something that just really pulls at my heart, because I remember, going on house calls with my dad, and it was about the relationship, and it was about caring, as you pointed out in our last discussion. Most of what he could do wasn't much at the time. I mean, he had his little bag, and he had some antibiotics in there and some painkillers, and and a lot of the times they didn't expect him to cure them, and he couldn't. But man, it was about the relationship, and that's what stimulated my love for the profession in the first place. And then when I got out of training, it was like, well, something happened along the way that has sucked a lot of the joy out of it.
We became a big business, didn't we?
Yeah.
I was riding with old friend Clay Christensen. As young men, we spent 2 years together in Korea. I'm feeling a little guilty. We were, in theory, working on a paper on, he would say, the job to be done. What's the aim of clinical care? I was too slow. So I should have been faster. I was just screwing around. 3 things emerged on the evidence. Number 1 is caring, just as you outlined. Heal the spirit, reduce suffering, a mental state. I've discovered that I can change the nature of death. Any good physician or nurse can change the nature of death. And you know what I mean. Anybody who's done this knows what I mean. People value that massively. They're willing to pay for it.
Yeah.
It's the single most important thing we do. Number 2 is curing when possible. Heal the body, heal the mind. When possible, often can't. Number 3 is something called rescue. We need to believe that we've done everything reasonable possible when a loved one is facing suffering or death, or even just a human in general, or even just an animal. Interestingly, it's not strongly associated with life expectancy. Life expectancy has other sources. We're about 10% of life expectancy, maybe 5 to 10%. Now that's not trivial. 3.5 to 7 years additional life expectancy from what medicine contributes. But the big drivers are behaviors, genetics, and lived environment, physical environment, social environment, public health. We have turned into a business that is about making money as opposed to relieving suffering.
Yeah, there's no doubt that has happened. I mean, that's what we see.
And you know the effect that has on us and our colleagues within the healing professions. It basically violates the principles that brought us into the finest profession in the entire world.
I love it when you talk like this, Brent. I just love it. And you're right. Of course, it's my profession too, but you're right. There is that streak of altruism in every physician that I've met or was, at some point in their career.
Well, it's always underneath there, Robert. I've discovered over the
Yeah.
years that even in the guys who seem to be in it for the money, it's always a deeper layer, the purpose-driven life.
Yeah.
You need to be paid fairly so you can, feed your family and stay in a home. But beyond that, the real payback is that relationship, helping people in their hour of greatest need. That's what
Yes.
really counts.
Yes.
Purpose-driven life. And I mean, I'm not just talking for myself. This is well established. I mean, we know this. And we find ourselves trapped in a system that seems to work in exactly the opposite direction. Well, believe it or not, pay for value has at least the potential to move us back to being real physicians again.
It does. And that, hence my unbridled enthusiasm for keeping us moving along that path. Because
me too.
I think the sooner we get there, the fewer people we will lose. And I'm not just talking about health span or lifespan. I'm talking about the kinds of people that we want in the profession, the kinds of people
That's
that I
right.
want taking care of me.
Chris Chen, he claims that's what he's creating for the physicians he brings into his primary care practice. He claims CEOs are kind of this way, the money's just secondary, Brent. There's a lot of money there. I get it. But on the other hand, I think he really does see himself as doing exactly that, creating sort of a practice that, that a real physician wants. That's what he's trying to do. We need more of that. By the way, we need more of it that is also trying to reduce the cost of healthcare to patients, to take that money and feed it back so that care becomes more accessible on a broader scale. Okay. This is my favorite approach to diversity, equity, and inclusion. So there are two ways of thinking about diversity, equity, and inclusion. A real problem. So it is a real problem. I believe in it, and I believe we should be focused on it, right? Well, how do you approach it? One way is you try to make sure that everybody's equal. So I would prefer that everybody comes up to the top, then we all meet somewhere in the middle. Yeah. I know how crappy care can be. And I would rather that we get the crap out and get everybody at the top than just bringing everybody to the same crappy level.
I'm on board, yeah.
So
I've got some more questions, and these are things that I ponder that I'd love to have your take on. So one is, when I look at some of the stumbling blocks, that giant corporations are people too, in terms of their ability to contribute to campaigns. I think that's a mistake, and that our patent law now has gotten to the point where you can build a fence around your patent for years and years and years, even though you only had one idea. As long as you keep throwing up new fences. The whole process of drug approval at the FDA encourages incrementalism instead of breakthrough. It's not that 4 months of life is not important to a cancer patient. It's just not good enough for the technology of what we're capable of. And it's because you can make your billion by just doing a little bit better. You don't have to take that leap. And I think our drug approval process, which was started for good reasons during the AIDS epidemic to speed drugs to market, but it's fallen into a very difficult position. And the fact that we will allow you can talk about the dialysis industry, you can talk about pharma, and it's not bad people or evil companies, they're just following the incentives, but the incentives are so perverse and have gotten so twisted that we're getting exactly what we've designed it for, which is incrementalism and lots of wealthy people, but not much health care. Its
primary aim is to generate income, isn't it, instead of just to help lives?
Yeah,
that's what you're describing. I agree with you on all of them. And the list could go much longer than that. Now, I'm going to do a funny thing to you, though, Robert. It's a decision I had to make myself around these things. Okay. I believe this idea of inappropriate clinical variation, this idea of value-based care, the associated concepts, of course, it all lumps together for me under quality improvement.
Right.
I believe that's within our control as clinicians. So I'm looking for things that I can put my hands on. Right.
Yeah.
I to some degree, I don't know. I hope to get a resurgence of faith. I've lost faith in the ability of policymakers at a national level to have much of a positive impact on this. But what I see is a group of people of a like mind, that would be physicians and nurses and our other partners in the clinical enterprise. I think there are things that we can do that make a real difference. And the reason I really like them is because the power is in our hands.
Yeah.
I don't have to wait for those guys to get it right.
Understood.
So I tend to focus there.
You know, there are a few things that are more frustrating than focusing on creating change where you have no levers or power. You know,
Yeah.
that's a difficult task. But, you know, I guess what motivates me to even think about those things is what you mentioned earlier. And you've told me before that we're optimized for a different function in this country. Let's talk about behaviors and social determinants and all of those things that are far more powerful
Right.
in terms of longevity and health span. I don't see that actually getting addressed anytime soon, which takes me back to something that I've been saying lately is, you know, the only way to improve population health is to improve the health of a population. And that seems to be missed in a lot of the efforts that are out there.
Yeah. Now, wait a minute. I got to challenge you back on this just a little bit. I'm going to flip tables on you here.
All right.
I know that you were sharing with me some examples in your home system down there in Arizona that looked pretty darn impressive, frankly. You know, so what's happening there?
You know, this is when I have the pessimist sitting on my left shoulder whispering in my ear, these are the places that I go. But you're right. I mean, and maybe it is the best advice that I could get is, hey, Robert, focus on things you know and can do something about. And I do try to do that every day. But
I think that one of the things you can do is become a guide star for others. I've got this great cartoon. It shows this group of ducks in a V walking through a forest. And one of them points up to the ducks that are flying up overhead in a V and says, hey, look what they're doing. Look what they're doing. And I think those kinds of models of people doing it are extremely important to be able to see those models and then to share them broadly. And it's surprising how many of those there are when you start to really look around. It's a real cause for optimism. You know, it's down at a local scale. It takes real leadership too. It takes people with vision and leadership to make it happen at a local scale, but it does happen.
Yes.
And we get better. I mentioned it earlier. I was talking about what it was like when I was back in the 70s in my surgical residency. Holy cow, care has gotten better over those intervening years. I mean, it's night and day.
Yeah.
In those 50 years. It's so much better despite all of our foibles and failings and silliness. I think the same will be true for the structure and organization of healthcare. The change was so small that you didn't really notice it while it was happening, but it was happening. A piece here, a piece there, a piece over there. It was smart people, thoughtful people, dedicated people with a vision. Did it happen as fast as I would have liked? No. On the other hand, in ways that we usually can't predict, we follow the truth, we follow the data, we follow the guide star of our shared values, and it gets better. Don't lose the values.
Yep.
Don't lose that hope. And then when you look back, you'll see it and you'll say, wow, that's come a long way.
Brent, this is why I love talking to you. It really is a periodic realignment. And I appreciate your wisdom, because one of the things I'm reminded of is nobody was ever changed by criticism, really. People are changed by beginning to believe in what's possible and seeing models that they themselves can relate to. And that's what you're telling us is, hey, you know, it'll get there, just do your part.
It's so pretty when you see them.
Oh, yeah.
And frankly, with this, I'll leave it up to you to share what you've been doing. That's for you to do on another time. But I'm going to cue people up that some of the things I saw that you were doing were quite impressive, and I think deserving of close consideration and perhaps replication. And it was kind of nice. And I thought, wow, I wish I'd been there for that.
Well, thank you. I appreciate that. And, you know, once again, you've been so generous with your time. I can't tell you how important this is to me to have these conversations periodically with you. So I deeply appreciate it. And I think this is a good place on that note of optimism to wrap up this session. And I've got many more up my sleeve, so don't get too comfortable.
Anytime. One thing I can say, yeah, the trouble's getting me to shut up, not to get me talking. So.
That's a happy problem to have. I'll take it any day. Dr. Brent James, it has been a great pleasure, and thank you so much. And we will talk again very soon, I'm sure.
Dr. Robert Groves, I say the pleasure has been all mine, and I'm looking forward to it.
Thank you. And that'll be it for us. And we're going to say bye-bye.
You've been listening to The Groves Connection, your connection to the inside story on healthcare, featuring in-depth interviews with those who know. You can find us on Apple Podcasts, Spotify, and anywhere else you get your podcasts. If you like what you hear, give us a 5-star review to keep the connection going, and hit the subscribe button to be sure you never miss a beat. The Groves Connection is produced by Dr. Robert Groves. Original music, editing, and creative direction provided by Alden Groves. Production support, content guidance, courtesy of Janae Sharp and Elizabeth Barrett. Thank you for listening. The professional ideas and opinions expressed in this podcast are mine and do not reflect those of any current or past employers. Thank you so much for listening, and we hope you'll join us next time on The Groves Connection.